talked about earthquakes in Haiti and Nepal. You might remember all of that. It seems like a lifetime ago. And who would have thought that a year after that symposium, in a wildlife market in Wuhan, there would be emerged an infection that would sweep its way around the world. And as you know, in January of 2020, the first evidence of human-to-human transmission was noted for the SARS-CoV-2 virus, and then in March the WHO declared it as a world pandemic because there was free transmission of the virus between people within populations. And the world has changed. The world has changed beyond all recognition in 2020. We now know that over 100 million people have been infected with the virus. Some 2 million people have died, and the number's probably quite higher, much higher than that. And then this year, the UK will reach a sad milestone, a very grim milestone, where 100,000 people will have died within 28 days of contracting coronavirus. So terrible loss of life and a terrible effect on our economy, the way of life, travel, the community, and our own university. In the way that both staff and students are suffering. But on the plus side, the response of science has been truly, truly remarkable. When this virus emerged in the UK in March, we knew nothing about it. We now know from data, from science, that dexamethasone is a good therapy for improving survival. We know that remdesivir has a small effect. We know that anti-IL-6 antibodies can improve survival on people on ITU. And we also know that hydroxychloroquine doesn't work, and neither does bleach, as suggested by the former president of the United States. And in record time, vaccines have been developed. We've gone from nothing. I honestly didn't think we'd get a vaccine at all, let alone in this time. So real all credit to our scientific community to get to that stage. And Patty's Institute has played its role. Patty's Institute was timed perfectly. You couldn't have been more perfect in setting up the institute at this time in anticipation of such a pandemic. And the role of data and behavioural science in population health to improve survival has been critical. And UCL has played its usual role. It has been truly, truly brilliant. I have nothing but praise for our academic community. We contributed to the vaccine development, to the Oxford vaccine development. Daisy Fancourt studies have allowed us to understand the effect of lockdown on society. Our scientists sequenced the virus that led us to understand the emergence of the English variant, as it's now known, somewhere in southeast England and probably in Kent. And of course, we developed the CPAP Ventura device and articulated in the early days that putting people on CPAP was better than putting people on ventilators. And in those days, you cannot imagine how controversial that statement was back in the spring of 2020. So Patty, well done. Well done on setting up the institute. Well done on getting the timing so absolutely perfect. Well done on all the awards. Well done on your personal award and the awards for the centre, which are truly outstanding for such a young centre. So it is a real triumph for you and for all your team, and I'd like to pass on my congratulations. I'll stop there if I may, and I'll hand over to Ivan, who's going to introduce your inaugural lecture. So Ivan, over to you.
Yeah, thanks very much, David. A very eloquent introduction. I think inaugural lectures are probably one of my favourite moments at UCL. We can get together and celebrate the work that Patty has done over a prolonged period of time, including what David has mentioned very recently. And actually, Patty and I are fairly close because it was me that appointed her. And remember, we had a couple of conversations in my office and we got you appointed into IRDR. So I was really, really pleased. But I didn't know at that point just how successful you're going to be. I mean, with this new centre, with this series of team awards that have come in, with a huge number of grants and fantastic publications, and you've really helped to lead the way in terms of dealing with this crisis in the area that you're responsible for. So it's been really quite humbling and fantastic to see. I mean, you've really grown. IRDR became a department for the very first time in September 2020. And so it's the youngest department at UCL. And you are the very first person to have an inaugural lecture in that department. So that's a first. So really, really well done. We're looking forward to listening to your lecture today. I know it will cover a wide range of things, and you'll go quite quickly because I've heard you speak before, but we will all gain a lot from it. And I should say that I think the IRDR it's come to life as a department at a time, as David Lomas said, which probably couldn't have been better. It's advised UCL centrally about how we should deal with response. We went through this gold, silver, bronze structure to try and get UCL prepared, and that came from advice and actually tutorials from IRDR staff. And so it's been a really positive message. And so I think that the department's going to go from strength to strength. I think you're going to be playing a major role in that with your centre. Although I did say to Peter Sammons, we're getting far too many centres here, Peter, because I think there's about 3 that have all spawned out of IRDR already. So I'm struggling to keep track of them. But your one has been particularly successful. So I'd like to welcome you to give your inaugural address. So I'm going to hand over now to Patty.
Thank you very much, David and Ivan. It was amazing to get a strategic overview of UCL in this tremendously important time where digital public health in emergency couldn't be better timed. I'm really pleased to see that my lifelong passion to bring together the synergy between computer science, big data, mobile technology, and public health has suddenly become everyone's business. Everyone really is interested in how we're going to fight this virus. So it's my real pleasure to give my inaugural lecture, which, as Ivan kindly said, will look back, not just the last 2 years of dPHE, but also back into my lifelong career in digital public health. And I'll show you how a long time ago, in the previous pandemics, we already started looking into big data and social media to predict at the time swine flu. However, before I start my talk, it's a chance for you, for the audience. I would ask Phil to launch the first form, and it would be great if you take a few seconds to tell us who you are. So who is the audience joining us today at dPHE 2nd anniversary and my inaugural? You have 30 seconds to answer those few questions. And it would be lovely if as many of you do take an opportunity to tell us what you're here for, what you're expecting from this event. So it looks like we got lots of bachelor students, excellent, PhD students. We have healthcare professionals. We have governments joining us. That's also excellent. Wow, a lot of people want to learn about digital public health skill. That's excellent. That's exactly the right place you can come to get inspiration for digital public health. So 60% of you have chosen the first option. That's great. So the polling will finish in a few seconds. So you can see the highest percentage are PhD students. Fantastic. So welcome all PhD students. If you're thinking about your future career, it would be fantastic if you have inspiration from my lecture and from the fun following up. That's excellent. And we get many academics, bachelor students, and industry as well. And as I said already, the inspiration for the public health field comes top. 60% of you came here for the inspiration. That's excellent. So thank you so much for sharing your views in the poll. And we're going to continue with my lecture. So the dPHE Centre was set up only 2 years ago, as David kindly mentioned. And it couldn't be at the right place at the right time. Of course, we didn't know there's going to be a COVID emergency coming up. It was right behind the corner. And we were right to hit the major cornerstones of any academic interdisciplinary activity. We obviously conduct cutting-edge world-class research. We involve in teaching, so it's great. We have so many PhD and master students joining us today. We, of course, are working with the community, so we're doing outreach activities. We work with public to engage and disseminate the outcomes of our emergency results. And also, we run a number of events. The biggest event is a conference I launched 10 years ago, Digital Public Health International Conference, which brings together those number of different labs between public health and computer science to discuss how to advance this exciting field. We have had swine flu, we have had anthrax, we have had SARS and Ebola pandemics, and the media do not hesitate to make the worst tragedies the headlines. And you can see I've picked up some of the UK tabloid media, which of course are very interesting in reporting news stories about public health in their own way. We also have recently politicians getting into the media and social media again, and unfortunately, in some cases, spreading regrettably fake news. So there's Joe Bolsonaro from Brazil on the right side, and of course the US president, the US former president, has played a major role in downplaying the role and importance of the deadly COVID pandemic. So we as researchers can also understand it's not just a one-way system of media traditionally disseminating information to public and scientific community to scientists. It's also the information coming from public, from citizens all over the world in this big data social media world, which influences what we think, what we believe, and how we respond. So looking at disasters and emergencies, you can look at the physical disasters, you can look at health disasters. We all are kind of sharing traces of information, sharing information needs and concerns through social media, through information networks, our number of followers on Facebook and Twitter, and all these actually are creating signals, and signals which could be minded in order to understand what's going on for early warning and event detection. And also it could be used in a two-way fashion to inform people about their decisions and about how to respond to potential risk and danger in the right way. So the first thing we have been looking at, and this transforms us 10 years back to 2009, it was the previous pandemic. It was the swine flu. At the time, Twitter was a brand new social media. It wasn't used by politicians, and there were no robots and bots and fake news at the time. It was a kind of a geeky teenage tool. You even have to type RT if you wanted to retweet. This is what Twitter was like in 2009. And my team at the time at City University investigated the role of the social media for early warning and prevention of a upcoming spike in the 2009 swine flu. VMT has chosen this project as one of the ideas which will change the healthcare by 2020. And this is almost prophetic, isn't it? I was at Finale, I didn't win the best idea for change by 2020. It feels like maybe the BNJ could have guessed that in 2020 we will be facing the massive, biggest global pandemic, which is changing and destroying lives all around the globe. So which ideas we had actually made the biggest difference by this crucial year 2020 was already discussed 10 years ago. So if you're interested, we can post a link to this film BNJ has shot about this specific study 10 years ago into the chat for you to look at it in your spare time. So what we have actually discovered investigating a large data set in 2009 was we could have an early warning opportunity using Twitter signal. Not the number of cases, of course. It will never be able to detect this from social media. But as you can see on this graph, the big spring spike in swine flu 2009 epidemic could have been predicted by Twitter, which is the kind of gray line, having a massive discussion about 2 to 3 weeks before the official authorities in the UK, it is the Royal College of GPs, have collected the data from patients who have visited their GPs, and they have notified and reported the cases to the national level. So the HPA at the time would have known if such system was in place in a real world up to 3 weeks about an upcoming spike. And the same results were demonstrated from the US. They were comparing CDC data against American-originated Twitter discussions about swine flu. So 3 weeks is actually quite a lot for preparedness, preparing your staff workforce, gearing up towards an upcoming influx of patients into the GP surgeries and into hospitals. So the early warning opportunity of social media has been demonstrated and is amazing. At the same time, it hasn't really matured much to become a kind of mainstream system to be used in epidemic intelligence these days. The other source of data, which is coming from the users on the ground, has become known as participatory surveillance. So it's no longer just the GPs and doctors who are reporting the cases through the official channels. It's also the citizens. It's also healthcare agents who are, in this case, visiting properties to combat mosquitoes in Brazil, who can be reporting their data and their findings using mobile technology in a participatory, crowdsourced way. We worked very closely for 4 years with our colleagues in Brazil, in the state of Pernambuco, the tropical part of Brazil, where Zika virus is endemic. Using a mobile app we have developed and working with agents, you can see the agents in a workshop meeting on the left side picture. They are using the phone to record the potential hotspots around the mosquitoes. And our research project is looking into developing an early warning tool, which is bringing together the data from these agents visiting the properties, together with Internet of Things devices, and also looking at weather predictions to be able to predict where the mosquitoes are likely to occur in those dwellings in the near future, so as the agents can direct their access to where the need is the highest. This is what the app looks like. And it's in the city of Recife, and it's the capital of Pernambuco, where we have quite dense communities where Zika virus is unfortunately rampaging, and this is where the agents need to be focusing on the hotspots, the high priority occurrence areas for the mosquito using our project. Well, bringing it all together, I have worked with my colleagues in ECDC and WHO, and again, it's my pleasure to have a colleague from WHO joining us in the panel later, looking at how we can bring it all together, what kind of framework we need to be able to survey all the information sources from social media, from the traditional surveillance, although it comes with a delay. Also from the participatory system, which provides the event being GBA located, and understand the signals and actually validate the signals to make sure we clean the data, we clean the noise, and we focus on real events which we assess using a given assessment methodology defined by these organizations, so as a response could take place in a much more organized and timely fashion. The Medi+Board framework project has developed a framework to bring together routine surveillance data, epidemic intelligence sources from news and social media and Twitter, and also it brought together a populational data, just like the agents reporting the mosquito occurrences in Brazil, from crowdsourced activities, to understand from the plenty of those information sources where the real risks actually are and what needs to be alerted to the authority. Moving on, social media obviously has got this immense role as an early warning opportunity and system and understanding what people actually think, but it also could be used in a negative way. As we all have seen, some of the major political decisions in the last few years, the Brexit and election of the Trump president, have also been believed to be partially enabled through social media discourse. In public health, one of the biggest issue, which is having a massive presence in social media, is vaccination debate. We are having a hot vaccination debate now with the COVID vaccine being so fortunately rolled out, as David said at the beginning, quite early enough. But there is also a lot of anti-vaccinations lobbies and anti-vaccinations groups spreading fake news and misinformation through the network. Our Medi+Board project was a back version with data sources focusing on social media and media covering vaccination debate around HPV vaccine a few years ago. There was a work done with collaboration with London School of Hygiene and Tropical Medicine. And we look at obviously having the dashboard to give us information about the information, the data sources, the media coverage, to know what the frequencies and what keywords were trending in which time of the study period. But the most important findings in this study was looking at how the information is disseminated, how it flows through the social media network. So this funny colorful graph is actually representing users who are moving, tweeting, retweeting, and mentioning certain tweet or certain information through the social media. And this kind of graph, this live graph of information dissemination and diffusion, helps us to understand who are the key people who play a role, repeatedly tweeting fake news and dissemination news, who need to be addressed by intervention by public health authorities, and also in collaboration with the social media giants, who should take much more responsibility of stopping and spamming out misinformation on their platform. Again, going back to swine flu, we look into an important correlation between media and social media around the most important event of the swine flu pandemic. It was the WHO declaration of swine flu being a pandemic on 11th of June. We look at what happens on Twitter. Twitter has gone crazy for 25 hours after the declaration. The word pandemic has been trending, and it was magnitude more higher frequency of this word in comparison to any other keyword on Twitter throughout the 2009 study period. So we looked at what Twitter was disseminating about the formal notification of swine flu being a global pandemic. And we have discovered that for a few hours, there wasn't really much happening on Twitter. And then CNN, the red line, covered this news, and Twitter has started retweeting the link to the CNN coverage. But as you can see, when the BBC came, even though it was about an hour and a half later after CNN, BBC immediately shut up and was the highest retweeted information source covering the pandemic declaration throughout the study period, 24 hours after the declaration. You can see at the bottom of the graph, CDC, WHO didn't really make much traction on social media at the time. Things have improved, of course, but still, working with the public health agencies like BBC is essential for risk communication and full embracement of spreading the information to citizens through social media. The second big area of my research has been looking at using of serious games for antibiotic resistance and prescribing. And I will introduce two strikingly different projects here. One of them is a app for training for surgeons in Nigeria, where we use a decision support gamified app helping to encourage compliant behavior in terms of prescribing compliance with WHO guidelines, and we measure a behavior change at the point of care. The second project was aimed at children. It was a large EU initiative in Framework 6, and we have got games developed for junior, primary school and secondary school children in 10 countries in Europe to learn about hand and respiratory hygiene and also antibiotic resistance. So GAPSA is looking at decision support in Nigeria to encourage prescribing in accordance with WHO and Stanford guidelines. It's addressing one of the major issues of antibiotic resistance we are facing today. And the major focus in this project is looking at the issue of overprescribing and prescribing for longer periods than is recommended necessary. We work with 3 amazing hospital sites in Nigeria, 2 in Lagos and 1 in the Delta, where we have recruited over 60 enthusiastic surgeons who were using our app for about 9 months periods to record almost 300 decisions about prescriptions for surgical site prescriptions they were making with their patients. The app has been giving them feedback. So it's a decision support persuasive technology, encouraging people to change their mind if they recorded something which wasn't in line with the WHO and Stanford guidelines. So you can see at the bottom, they were given either red or green feedback if the decision was or wasn't in compliance with the guidelines, and they were encouraged to rethink if they perhaps should be prescribing a different antibiotic or maybe shorten the course, the duration of the antibiotics they are prescribing. You can see this little dog is the mentor. In persuasive games, the role of mentor is have some kind of authority, which is encouraging to make or change the decision for the user. We have done an array of different mentors from obviously humans, doctors, males, females, objects, and also animals. And in an exciting fieldwork collaborations and focus groups, Nigerian surgeons have chosen a dog to be their mentor and gave us exact definition what the dog should look like, wearing a white coat, a stethoscope, and glasses. So it's a doctor, a dog, who is the most powerful mentor which actually enabled a behavior change. We have measured several decisions throughout the year. So the most successful one was change of a decision with regards to antibiotic surgical procedure being of high or low risk. It was almost 70%. And then decisions around the correct use of antibiotics, called SAP or duration, was around 10 to 15% positive change in improving compliance. So really great result. We're grateful to our Nigerian collaborations, and also I'm proud that this project was receiving several international and national awards. EduGames for All was a children's project. Children were taught through a little platform game with encouragement of factors, the basics about their health, hygiene, and antibiotics. So in this example, the game for the junior children is teaching them about how food course needs to be finished, how the antibiotics should be finished in order to get rid of an infection in their body. This horrible purple infection you can see on the picture. So if the player doesn't use all the capsules of infection, it will lose life and the infection will grow back. On the second picture, it is teaching the kids that there are also good bugs. Not just the bad bugs making us ill, but good bugs we are using to make bread or yogurt. So in this case, the player needs to push loose selective bacillus into a glass of milk, and after 3 looses are pushed into the milk, it turns into yogurt. And the one with the yogurt was actually successful in terms of the highest significant knowledge gain after playing this particular game. The teenage children in this project, they were given a CSI-style game. So games which are so-called interactive digital storytelling games, where they need to investigate an outbreak. They need to find out who was spreading the viruses or bacteria. They can collect samples like detectives and get them tested in the lab. In order to understand how they actually improve their knowledge, we have worked a novel seamless evaluation framework where we have built the questions into the dialogues they were having with the characters in the game, and we were testing their knowledge seamlessly in the app, and we could have demonstrated a knowledge improvement and better understanding after playing the game. One may think, well, games is just for children. This is not something which could be a public health intervention for adults. Yes, it could. But the most helping project where a serious game has been successful in improving public health is a project called Mantra. It's maternal and neonatal technology for increasing health in Nepal. We work with disadvantaged women in rural part of Nepal who normally are meeting once a month in a women's study groups with volunteers who are teaching them about their maternal health, pregnancy, and health for their babies. We have developed an app which, for many of them, was the first experience of using a smartphone technology. We have to even teach them how to do drag and drop because they didn't understand that this is how you operate a touch screen. Many of these women, unfortunately, are very poorly educated. We even face illiteracy. So the game had to get only pictures and pictograms to communicate those conditions about their maternal and neonatal health and understand what is risky for them, where they should demand a transfer to healthcare facility, and perhaps what isn't too risky, and they may be able to manage the condition themselves. A number of focus groups has been repeated to make sure the pictograms were culturally appropriate and communicate the message to the women. And when we evaluated the success of the game, we were proud to see that they have good significant knowledge gain, apparently mainly around neonatal health and also geohazard. But also from the focus group and the qualitative component of the project, they really enjoyed the game. They loved playing it. They didn't want to stop the focus groups. So it was great that they actually understood this is not just a bit of a fun and technology, which for many of them was beyond their financial reach. It also helped them to be empowered to argue for healthcare decisions or access to healthcare facilities with their husbands and with their family members when and if they need help. So last but not least, one of the projects I am really proud of is Emmerich. I have started working with Emmerich in 2005, so 15 years ago. At the time, The National Audit Office felt that there is not enough being done by the government in terms of keeping hospitals clean. It was, some of you may remember, even part of the political discourse before the elections, how hard it is to keep hospitals clean, those big billboards. So at the time, it was recommended to set up a resource which will deliver one-stop shop for infection control for it. And we delivered. And we delivered information to NHS professionals, mainly nurses, who were in charge of implementing infection control policies and being on top of the latest evidence. And it's called Global, because it was one of the resources at the time genuinely delivering free of charge evidence-based information. We had users from all over the world, from 159 countries, who all have been using it in their countries. We have a special branch for African users, disseminating and sharing information appropriate for low-income settings. And we also have the opportunity to collect data from the website being accessed. So we knew from the search web logs on the website what the people are searching, what the information needs are, when and why and what actually is their main, most important information. And in a longitudinal study, we correlated the data collected through the NBID website, which was predominantly coming from professionals, with public interest in infection. In this case, it was looking at influenza. And we also look at the third part of the triangle, how media at the time were covering influenza discourse. So bringing together the weblog information from NRIC with the public information searches on Google, and also the media coverage by a website run by Guardian, we have discovered that there has been some correlation. You can see, again, it was a spike year. There was a massive spike, the black spike, which was from the Google. So Google has actually demonstrated people have been searching around infection again around the spring swine flu outbreak 2 weeks before the green line, which is showing the spike in the media coverage. So the media kind of picked up on the wagon 2 weeks after public already had the disease or the symptom, all the worries to learn more about the disease from the internet. You can see the red line at the bottom. That's the NRIC searches. That's the professionals. It doesn't seem to be reflecting the massive public media interest. And in fact, those spikes for the red line are much more related to new publication of guidelines by the government or new evidence coming out. Moving on to 2020, of course, COVID was a massive tragedy, but also a massive opportunity. So dPHE has sprung into action and has developed quickly 3 projects. So one of the projects is my activity on my lockdown journal. So if you are not using this app yet, it's your chance to download it. The app is now having over 1,100 users, and it is providing an opportunity for people initially in the first lockdown, throughout the post-lockdown and second and now third lockdown periods, to record the activity and journal what they're doing every day, to be able to have some sense of time, to be able to actually reflect about how they are day by day, which suddenly all keys seem to be looking the same, how they actually could be structured in a way which is improving mental health and well-being. This was also backed and informed by a major study called Zoom or Not to Zoom, which again was running in different 2-month periods to reflect the different phases in the lockdown and post-lockdown time. We have over 8,000 users giving us answers on the Zoom or Not to Zoom study. And again, we have demonstrated that a lot of the people in the first lockdown from the initial results seem to be turning into doing sports more often than before. The majority at least once a day. And also a lot of people reported practicing yoga, praying, and meditation. There also was a disparity between the ages. The young people below 25 seem to be coping worse than the people over 65 in terms of their mental well-being. The app and the survey was also backed up by a social media competition. So this picture is one of the first winners of a weekly competition where anyone can post a picture and can be part of our weekly competition to win the My Activity Journal prize. Our second big project is building on our previous Twitter experience, and this project is harvesting Twitter discussions about COVID since April 2020, looking into citizens' response to major government policies in a number of study countries, and also looking at the kind of government response which is either enforcing the government or where there is a conflict with the government communication in various countries around the globe. On this slide I've just chosen as an example, we can see that a lot of the people have been actually sharing their criticism and dissatisfaction with the government policies. So the red line is a US discourse, which is quite heavy on the criticism side. The blue line is the UK. A lot of people have been also discussing the lockdown and compliance with the policy, and also discussing the role of the NHS. So this is an ongoing study where we are looking forward to getting the final results when the epidemic is over, to be shared with you in the future. And finally, our third COVID project, which sprang from our collaboration with our Brazilian colleagues, was looking at the big data tracking and using drones for COVID-19. This work was also helping local authorities in Pernambuco, the state where we work, to understand and predict the cases. And also it was looking at how drones as a new technology could be used to monitor population movements to enable predicting of COVID-19. Wow. So this all hasn't been done in over 2 years. Obviously, it goes back to my previous work before I set up dPHE. However, I've been so fortunate that the dPHE as a team received the Rising Stars Award 2020 for our work on the COVID App project, and we won the Best Project of the Year. So congratulations to the dPHE team for winning such a prestigious and important award. Of course, it's not just research. As I mentioned at the beginning, the 4 pillars also include our programs. So I am teaching a digital health epidemics and emergencies module in IRDR. Students can also register for data science pathway. And of course, we have many PhD students who are interested in studying digital public health. We're also planning a master program in digital public health and emergencies to be launched soon, and also summer school. Our 2 major events on the publication and dissemination side is our conference. So I established a conference on digital public health in 2009, and it's been going on for almost a decade now. It's publishing proceedings in ACM and was also accredited by IFEA. A sister project is a public health journal, which has been running since 2012. It is an open access journal published with Frontiers. But last but not least, public engagement events include masterclasses and workshops and skills building events using hackathons, panel discussions with MSF, for example, and other events where we are promoting the cutting edge innovation and research in digital public health. So to close my talk, I am proud to have received many prizes in the last few years especially, and my team has been so fortunate to win the prestigious Team of the Year 2020. And also for the Zika project, I received Innovator of the Year 2019, and for the achievements this year in the App Project Innovator of the Year by Computing Women in IT Excellence. We were obviously widely covered by media, celebrating our achievements both at UCL nationally and internationally. I'd like to thank you to everyone in the dPHE team, all our staff members, our students, our interns, and people who work with us in any country and continent, which actually was the case in 2020, when we physically haven't met together since the lockdown started, and still the team have doubled in size through summer interns and worked very effectively together and winning such a prestigious prize. Also, the Centre would have not started and not been so successful without a major support and help by 3 individuals. I'd like to thank you to Caroline Wood, who is a former dPHE manager and a researcher in behaviour training, who did an amazing job in supporting me and working with me on establishing dPHE and the conference. I'm also grateful to Peter Summons, the head of department of IRDR, for his leadership and support. And also to my mentor, Professor David Price, UCL Vice Provost Research, who've been giving me invaluable help and support throughout my career. So to contact me and contact the Centre, please follow us on social media. And this is the end of my inaugural talk. And I'm delighted to move on to the second part of the event, which is an exciting panel debate. The panel is chaired by Professor Ijeoma Uchegbu. Ijeoma is a very energetic UCL Professor International for Africa and Middle East. She also is a professor for pharmaceutical neuroscience and chief scientific officer for Nanometrics, a spin-off company she established. She also is the UCL Provost Envoy for Race and Equity Panel Chair. So I will hand over to Ijeoma to introduce our panelists.
Thank you so much, Patty. I mean, that lecture was absolutely phenomenal. I mean, your reach is international. It really is phenomenal. And lots of different concepts have been explored. It was amazing. So now the panel has to do it justice with a very, very lively discussion. And I'll introduce my fellow panelists. I'm really pleased to have this high-profile panel. So first of all, Professor Jones Albuquerque is joining us from Pernambuco Institute for Risk and Disaster Reduction, all the way from Brazil. Hello, Professor Albuquerque. Welcome to UCL virtually. We also have Professor Olasade Ogunshola, who is joining us from the College of Medicine, University of Lagos. And Professor Olasade Ogunshola is a provost of the College of Medicine. And it's wonderful to welcome you, Professor Ogunshola, because I actually used to work at the College of Medicine about 30 years ago. And the other panelist is Dr. Andrew Likaka from the Ministry of Health and Population in Malawi. Welcome, Dr. Likaka. And Dr. Philip Abdelmalik, who's joining us from WHO. He's a public health team lead at the WHO. And we have Tariq Khokhar, who is the head of data for science and health at the Wellcome Trust. Thank you very much for joining us, Tariq. Really nice to meet you. And of course, we have Patty on our panel. And so you have our panelists. And if you want to pose questions to the panelists, please post them on the Q&A function at the bottom of your screen. And then towards the end of the discussion, we'll take your questions. And so now I'm going to start asking the panelists questions. Welcome, all of you. And we're going to, first of all, I mean, it's all about beyond COVID-19. But of course, one thing, COVID-19 has been an absolute disaster for the world. There is no question about that. But one thing it has done is it has raised awareness of science in the minds of the general public. Most people know that the vaccines have come from science, the social distancing advice has come from science. I'm going to ask you, each of you, how do you think you can harness this new rock star status for science? I'm going to start with you, Professor Albuquerque. Is there anything we can do to make sure that this endures past COVID?
Yeah, thank you, Ijeoma. Thank you, Patty, everybody, my friend, Andrew Likaka, and the other panelists. Thank you. Yeah, we are on the lights of the things, and here in Brazil, I try to put a IRDR institute, like Patty has his own institute. So Patty works with us for several months since they start the COVID, and beyond the COVID, we will continue to maintain our platforms with drones, with thermal images, with satellites, with crowdsourcing, with communities advices. Patty and Jimmy Owen, that is another professor from UCL, did videos in Portuguese. It was amazing. And we circulated their videos into the communities to them to see that this is a global problem. It's not a Brazil problem. We have a huge problem here. Pat put in the slide, our president is not good to the pandemic situation, but the community are now consciousness that we are in a huge problem, that all of them do not know until now how to break this. We are trying. We are trying with vaccine. We are trying with the amazing projects that the Patty did, and with crowdsourcing, with monitoring, with games, to try to see if the people absorb what the problem is. Dr. Likaka is our partner. We put the same systems that we did from Brazil, we put in Malawi, and Dr. Likaka has an amazing work, because Malawi and Pernambuco, that's where I am, has the same area. Malawi has the double of population and a little cases of death. And here we have 10,000 deaths. It's very sad. This is our challenge now. Thank you.
Thank you very much, Professor Albuquerque. I'm going to come to you, Dr. Abdelmalik, and talk about the fact that WHO has been in the news every single day. How do you think we can harness this newfound trust, appreciation, and respect for science going forward?
Well, thank you. And first of all, many congratulations to you, Patty, and also to your team on the achievements. So just have to sort of throw that in there. And thank you for this invitation. WHO obviously has been very heavily impacted by this. I mean, everybody in the world has, but WHO especially, as you know, has been under the lens in a lot of different areas. And so certainly as part of this, we are looking, and have been now for years, at how we can harness, it's not just about science, but really for my team specifically, how we can harness these various technologies in order to improve and ramp up the speed with which we can identify, analyze, assess, and respond to these sorts of threats. You know, one of the biggest challenges, and I remember Patty was on this panel with me many years ago at a conference where I was talking about we need to be thinking ahead about how we can harness sort of not just citizen engagement through participatory surveillance, but through wearables and the internet of everything now that is around us. And there were some people in the audience who challenged me on that and said, what is my incentive to participate? How do you incentivize the population? And it was a bit of an awkward discussion because it didn't matter what I suggested. That individual said, I'm never going to share my data. I don't trust these organizations. And so I almost feel like sort of trying to connect with those people now and saying, is this incentive enough for you? And so I think, you know, whether it's through gamification, whether it's through, these tapping into people's behavior, and behavior change is one of the biggest areas that we need to be thinking about in terms of science. We can come up with all sorts of technical, robust scientific solutions, but if we're not impacting people and changing behavior, I think we're sort of going down the wrong road. So these are some of the things I think at WHO that we're really thinking about. What is our digital strategy moving forward so that we can actually impact the world around us through collaborative and coordinated activities, not through directives and just guidelines, because those will only take us so far.
Wonderful. So practical strategies is really the focus for the future. And Dr. Andrew Likaka, let me come to you. And we've heard that the death rate in Malawi is incredibly small. Of course, every death is a tragedy. And then we heard in the beginning, David Lemons talk about the number of deaths that we would have in our country. So, how are you harnessing this new trust in science in your work?
No, thanks very much, Prof, and congratulations also, Patty, the team for a great work, enormous work, contribution to science. I think COVID has provided a big opportunity to challenge how probably the lag time between policy and implementation. COVID has extremely put science ahead. You see that the development of the vaccines has been quite robust. Actually, has put most of the policy regulatory frameworks behind. When we look at the new innovations that have come on the practical scene, most in Malawi, for example, there is Access to Information Act, but even though there is that act within the registration passed by Parliament, issues of confidentiality matters, privacy matters. Some of the applications that have come in during COVID-19 goes beyond those barriers. For example, how do we ensure that we track contacts? With technologies like mobile phones, one would want to be tracking using the mobile phones. But there is a limit, and it's not easy to break and cross through those. So I'll say that at national level, ministries have to start thinking about how to change the way the policies are advanced, because science is moving ahead, and it's time to be flexible with even the guidelines that we are developing. I think I must also indicate that COVID has challenged the context where we operate. You agree with me, Prof, that digital illiteracy is quite high in most African countries, including Malawi. So most of the applications are coming, new applications. Normally, the developers of those applications don't think about the environment where those applications have to be applied. Some health workers are using the applications for the first time.
Yeah.
So that on its own, I think is something to be really harnessed and thought through. Thank you.
Wonderful. Thank you very much. And I'm going to come to you, Tariq Khokhar, now, from the Wellcome Trust. How is the Wellcome Trust going to respond to this? I mean, of course, science has always been at the forefront of your minds, but now you're able to connect with members of the public.
Thanks so much. And thank you also to Patty for the invitation, a great lecture, and again, congratulations on everything you've achieved at dPHE. And yeah, I think great question about Wellcome. I think one thing I think everyone's realized is it's important. What you do during a pandemic is important, but what you did the 5 years before it are possibly even more important. And I think the experience, certainly in Europe, of going through a pandemic of this scale will hopefully kind of keep preparedness front and center and make the argument for investing in preparedness that much easier. That's what I'm hoping becomes the main takeaway of the crisis. Maybe two other points. I mean, as Patty said at the beginning of her talk, there's never been a time where so many in the public have been paying regular attention to daily data, the trends they contain, what those trends imply. And I hope this kind of inspires a new generation of people to become a bit more data literate, a bit more interested in this sort of information. And I think throughout it all, it's shone a light on a few real bright spots of communication, actually, of these data. So the brilliant work of folks like John Byrne-Murdoch at PFT, folks like Hannah Ritchie and Max Roser at Our World in Data, or things like the COVID tracking project run by the Atlantic in the US, collecting and publishing the most complete federal and national data set on COVID-19 in the US. These are all great examples for others, and I think particularly in academia and in public health, about how to work with data in the public interest and how to effectively engage with and communicate with the public. And maybe the last point, if I may, in the kind of in the background, we've been talking about trust. And I think rather than thinking about trust in the abstract, we need to think about what it really means for research, trust, and data and technology to be trustworthy. And I think that the thing that folks forget most about being trustworthy is just being visibly and relentlessly competent. And I think things like the Excel error in the NHS test and trace system in the fall brought that kind of thing to light. We're literally making life and death decisions right now in real time using public data. So we should be trusting these data like we trust the water that we drink, like we trust the food that we eat, like we trust the medicines that we take. And this really requires reprioritizing the care and attention and resources that we put into this kind of data infrastructure. So I'm hoping these are some of the things that we take away from this pandemic.
Brilliant. And so, Patty, I'm going to ask you, to just a couple of sentences on this topic. I mean, you spent most of your career actually harnessing information from members of the public to inform the debate. How do you think we can capitalize on this newfound trust in science?
Thank you so much for an excellent question, Ijeoma. I think we really are seeing this regained trust and a regained importance of so-called experts back in the front line of obviously policymakers and citizens globally. And it's a great opportunity after this time and period of fake news and devaluing of expertise and devaluing of the importance of scientific discourse for decision making. So yes, what do we do about it? And I really like what Tariq said. It's not just what we do now in the emergency. It is how we respond after COVID and how better we prepare for the next emergency. There's going to be another pandemic in 10 or 15 years. We have to really capitalize the existing interest, the popularity, and the shared value of our collective understanding from the political level, from WHO all the way down to the citizens level, in channeling the policy decisions and financial resources and international collaborations we have all enjoyed through the emergencies for better preparedness.
Wonderful. Thank you so much. And remember, members of the audience, to post your questions in the Q&A function at the bottom of your screen. And so I'm moving on to the next question. And Patty, I'm going to ask you to sort of kick off here. You really demonstrated that you could actually use readily available data to predict the onset of a pandemic. And you showed that really quite clearly with your work. And I'm just wondering, how can we make these models better? Because we had a lot of talk about modelling in the UK. Did we overestimate the impact of COVID-19 and things? Why are they not absolutely perfect yet? What's missing?
This is the holy grail question, Ijeoma. This is exactly the holy grail question. And I can see sort of Abdelmalik smiling, from WHO. So I'm sure he will also be able to add his part of the story. Yes, I think we must admit that despite the opportunities of social media and all these new big data sources, we actually really harnessed these opportunities for real-time improvement of public health response. We're still on kind of academic modeling, academic projects, pilots, which demonstrate the chance, but haven't kind of grown to the level of maturity and integrated interoperable solutions at national and international level, really being able to kick into action and inform the policymakers when a new pandemic or even new outbreak is actually starting. And I can see that two reasons. I think one of the question is, it's a long way from academic research to a mature, robust, real-world solution. And I think we haven't quite funded and haven't quite got the right partners in place to actually make it happen. Secondly, is the access of data. And I haven't really given too much space to it in my talk because it would have gone in a different direction. But a lot of the data we are using are, one, relying on, say, Twitter and social media, which is one of the organizations making the data available for researchers free of charge. But there are billions of petabytes of data collected by different IT companies and mobile apps and Google searches, which are not available for public health. They are kept in a private corporate ownership used for advertising revenue. And this is the kind of imbalance we have to change globally at the political governance level.
Wonderful. I'm going to come to you, Dr. Philip Abdelmalik, and talk about modelling and predictions. And is it something that WHO is going to be doing more of now? We're anticipating more pandemics.
Yeah, thanks. It is a great question, and it is something that I can't even count the number of times now that we've talked about predictive analytics and modeling at WHO every day for the past, over a year now. I think what we're really talking about here is we're talking about public health intelligence, we're talking about public health surveillance, and these concepts are not new concepts. I mean, public health intelligence has been named that, called that in documentation going back at least in the mid-1800s, if not earlier. And public health surveillance is way older than that, and we know of many instances in the past about that. And at the heart of these really is data. So the idea of collecting data, turning that into knowledge of public health. So, you might think we'd have it perfected by now, given how old it is. And, as Patty has noted in her presentation at the beginning, we've made significant progress over the years as data has grown and our ability to use it has grown as it's become democratized. I know you probably hear my kids in the background. I apologize for that, or I don't. But, there's this growing ocean of information that we keep talking about, tapping into this data source, tapping into that data source. But as we're thinking about this at WHO, how do we improve models? How do we improve our predictive capability and our forecasting? What at least the discussions have come down to, the foundation is data, but it's not about collecting more data. It's not about these siloed data approaches that we tend to fall into. It's more about mechanisms that allow us to support the sharing of sort of standardized data, making it easy and clearly beneficial to the world in terms of its accessibility. And when I say mechanisms here, and I know I'm talking a little bit long here, but I'll start to wrap this up. I'm not talking about applications. Those are pretty easy to develop. Tap into Twitter, tap into Facebook, whatever, we get a result. Okay, great. But rather, there's a deeper underlying need, and there are more complex challenges here. So, for example, what we've been talking about at WHO is globally supporting data architectures on which we can build global federated learning data models. This allows us, what we're really talking about is to start semantically linking data elements across data sets so we can look at the relationships across this data landscape. And by doing that, if we can do that, not only do we generate a picture of our existing knowledge, but we begin to understand things in a way that we haven't before and illuminate things that we didn't even know. And that's where the power of the data comes in. And that's where then predictive analytics and modeling then become more robust, and we have more confidence in those models. You're talking about trust. Trust, as you said, Tariq, it's not just in the organization, it's in the output of that organization and the transparency of that. So I think these are the sorts of things that at WHO we're thinking about, talking about, trying to incubate and then accelerate and grow. It's this ecosystem of data around the world, and how do we encourage that, and then how do we build applications on top of that ecosystem, applications that talk to each other.
Thank you so much. And Tariq, I'm just going to ask you to just briefly comment on whether this is something the Wellcome Trust will be looking to fund projects in. The issue of having access to the data, Patty has talked about, and I think it's still relevant because some of this data is siloed, private. So how can we unwrap this problem? Is it funding?
Yeah, no, it's a great question, and I think you've really hit on something here. Just as important as sort of funding research into this area is funding the tools and data that underpin research is sort of just as important. So often teams are building their own kind of data and tooling pipelines from scratch. Often they're relying on personal or opportunistic connections with data providers or companies, and that's just not a way to ensure that this research is happening in an equitable way or in a way where it's sort of most needed. So, for example, at Wellcome, we're really pleased to be supporting a team called Open Safely out in Oxford, who are developing a new open platform for rapid, secure analysis of electronic health records at scale. And they're, a team who back in the spring last year identified the higher risk of in-hospital death for folks from ethnic minorities in the UK. And that was a piece of analysis that was made possible because they built a tool that allowed researchers to access this data set in a sort of rapid, sort of secure way. So I think that's totally right. I think investing in that sort of soft infrastructure to allow more research to happen is vital. Thanks.
Excellent. Thank you very much. Dr. Andrew Likaka, I'm going to move on because it's all about beyond COVID. That's what we're supposed to be talking about. And I'm going to move on to other threats to humanity. So COVID is a threat which is being addressed, but there are other threats. And apart from climate change, we have the threat of antimicrobial resistance. And my question to you is, Patty showed quite elegantly the app that was developed to change behaviour. And I know, because I've spoken to Patty about this work, that behaviour was changed. There was less antibiotic prescribing. What's your opinion on using these very, very effective solutions to change behaviour in this particular area? I think you're on mute.
Yeah, thank you very much, Prof. I think that's a very challenging question. I think mostly in the context of Malawi. There are basics, I think, that we need to think about first to deal with antimicrobial resistance. First of all, the behavior in my country relates from both the supply and the demand and supply. So the health system in Malawi is heavily dependent on the task shifting. So we task shifted most of the operations to medical assistants. These are lowly trained personnel, health personnel, but they are managing a bulk of the population, and almost 85% of the population is in rural areas, and that's where a majority of the prescribers are lowly trained.
So what level of training?
Essentially, anyone.
What level of training do they receive?
Yeah, so anyone who comes. So these people have got a certificate in clinical medicine.
Okay.
So essentially, they want to manage the queue. One medical assistant on a daily basis is seeing an average of 300 patients. And all they are working on is just to manage that queue and satisfy these people. So it's all about giving what iron antibiotic available. So the public itself also demands, if they don't get antibiotics, they feel they haven't been assisted. So that's a dynamic that may be challenging when we are thinking about technology. I believe that technology works when technology is a solution on its own, but it can also bring a problem on its own. The context is very, very critical to look into when we are bringing technology, because we may be disrupting or make things worse on their own. But I think in the cities, using technology works. As I've already highlighted, we are dealing with issues of literacy, digital literacy, technology, behaviors even to accept technology among health workers. It's an issue on its own. So acceptance in cities is better than in rural areas.
Absolutely.
So that's something I think I can contribute towards that.
Brilliant. I mean, Patty, I'm going to come to you. This is a gift of a question. I mean, Dr. Likaka says, well, the barriers are completely different. How would you tackle this if you wanted to provide apps to change behavior in the clinical sense?
I think Dr. Likaka has really raised some of the most strategic and much more kind of a high-level challenges around antibiotic prescribing. And, mentioning things like, obviously, drug shortage and the costs and everything else, which our app did not deal with. All we will focus on in this project called GAFTA was enabling behavior by raising the lack of compliance or difference in compliance to the surgeons at the point of care. And in this regard, the app has been the first in the world actually demonstrating a behavior change. So what we would like to do, staying at this kind of personal individual decision level, is to... What are you doing?
Actually, believe it or not, there are some technology-related projects. I don't know if we're specifically deploying apps because there's a whole unit dedicated to antimicrobial resistance. So my team connects with that unit to look at how we can leverage technology, particularly in terms of detection. I mean, again, as a unit, I can't speak for all of the work that they do, which is really, really broad. But in this one specific area, we're looking at, things like tapping into publicly available information to look at early signals potentially that might come up, developing those sorts of technologies that help us to monitor and track what's happening, which might include prescribing behavior and what's coming out of that. And, Patty's talked a little bit about that. So certainly we are exploring as an organization all these different ways to fight a lot of these really top priority things that are of grave concern, and AMR is one of the ones at the top of the list. But I think one thing to maybe highlight is that in everything we do at WHO, one of our strengths is our ability to connect and collaborate, and those are the things. We're not all experts and on everything at WHO. Our strength is in being able to bring the experts together, contribute our own expertise as well, and together try to identify those solutions.
Brilliant. Thank you very much. I'm going to come to you, Tariq Khokhar, and ask you this question. And it's about translating research. So we're all academics, and there's nothing we like better than to do the research, to write the paper, and then to promptly forget it. But then, of course, we have to translate. Patty says no. We have to translate our research into real-world solutions. What is the secret? How can we do it better? I know the Wellcome Trust have a translational arm.
Yeah, no, great question. I'd agree with Patty shaking. I don't know researchers who fit that mold anymore. I mean, honestly, maybe three ideas there. So going back, just touching on the issue of antimicrobial resistance, I mean, there are like systematic issues that need to be addressed for translation. So things like funding mechanisms and regulatory incentives for, SMEs who are working on AMR innovation are just sort of, real blockers to making progress there. And I think that's probably the straightforward answer. The culture, resources, and support available for translation for startups just isn't what it could be. If I think about the UK, and it's easy to make comparisons with the US or Singapore, where that infrastructure is a bit more mature. But you just have to kind of look over the channel to the strengths of Germany's industrial strategy, or initiatives like France's French Tech Visa, which is deliberately making it easier to bring in talent to work on AI startups and this kind of stuff. So there's all sorts of interventions that the state can even apply and just create an environment in which this sort of this happens. So that's maybe the sort of straightforward answer. What I think maybe the more interesting answer is, when you take a step back, if you think of science as something that needs to be focused on solving problems that will make a difference to people's everyday lives, science is now like the ultimate team sport. And it's something I really love about Wellcome's new strategy, which focuses on these three urgent global health challenges of infectious disease, mental health, and climate change. None of these challenges can be solved by scientists alone, right? It requires the work of folks like artists. So, for example, the Wellcome Photography Prize, which I think the new edition is live now, but like last year they were looking for new ways to communicate about mental health. This is an essential part of moving the agenda on mental health, and it requires photographers and artists to work on it, right? It also requires the work of social scientists, policy experts, communication professionals, data scientists, research software engineers, and a lot of it boils down to the environment in which research is done. So if I had one sort of takeaway, it would be injecting a little more maybe humility into the research process and recognizing the value of different professional disciplines and experiences, and ultimately solving these problems that matter. So there you go, two takes on it.
Brilliant. So collaboration. Professor Albuquerque, I'm going to come to you. We've been talking about translating research into real-world solutions, solutions that are either services or products. And we all know that's very difficult. Do you have any ideas on how we can do that better? And you're on mute.
Yeah, sorry, my internet is so stable here, so now I am back with my phone. Yes, we can. I stayed in UCL during 2017 and 2018, and this is why I met Patty and all the guys, and I learned there, with you, how to do this. The simple way is to translate the complex systems into simple maths, simple figures. We did Albert Einstein model based on space-time prevention system to the pandemic, and we translate this into signals. So today, our government are looking this kind of maps and seeing 2-3 weeks before the starting of the pandemic, 2-3 weeks before, how will the things will behave, or how we suppose that they will, with 2-3 weeks. So with this kind of thing, this is not a simple mathematics, but when you see some maps that you can click, when you see, let me see, a drone image that you can see if some residences are more hot than others with the people, we can see if there is a supposed fever guy there. This is the project that we work with the guys from Patty and the guys here in the UFPA.
How was it to get the government interested?
Yeah, this is the main things is the the confidence of the data and the tradition of the institution. This is why UCL, UNICEF, the PAHO is our partnership, because we trust on each one. When Patty do something, I absolutely trust. When the WHO told something, I absolutely trust. Of course, they know what they are doing. So what we are doing here, translate the things. I showed some videos before here. This is why we put Jim. Jim is a professor from the medical school. This is why Jim is talking in Portuguese to the guys. This is why it's important here to Patty. Oh, let me see. Yes. Patty talking with the guys. This is important because when who is this guy? And what? Oh my God, he's the director of the. Oh, okay, he knows what she is talking about. You know. So this is kind of the trust of the information with the media, with the videos. This is what Professor Likaka is with us.
Excellent.
Because we trust on them. Okay, this is the simple way.
Yeah. So in summary, it's excellence, and from Tariq Khokhar, it is collaboration. So excellence and collaboration with a little bit of communication. Doesn't have to be in Portuguese, but it can help if you have a Portuguese audience. And I'm going to ask you, Dr. Likaka, about moving from the science base to a real-world solution. How easy have you found that? I found it incredibly hard.
Yes, Prof. I think this is a big issue. Translating science research to action. I think there are two things. The biggest gap is science has to respond to a policy question. So a policy maker like me, I have so many questions that I need the evidence to respond. Unfortunately, my questions are not. Tariq may not like them to fund them. Tariq would not. They may not appeal to Tariq or any donor to fund research to answer my question.
Okay.
Right? So that's number one. Number two is that academic research. Most of the research is done for academic field to progress academically. So the recommendations coming out, they seem like hitting the bar outside. I don't know what this paper was all about. It may be to add the knowledge, to bring new knowledge to the space. But maybe it's not answering to my, question as a policy maker. So those are, I think, some gaps that we need to work on. And I like the idea of the knowledge translation lab. These are, I think, institutions that need to be built up across countries, so that there is an interface between researchers and policymakers.
Excellent.
Thank you.
I'm going to ask the audience to post your questions in the Q&A box at the bottom of your screen. I'm going to go to you, Patty, for the final answer on this question. You've got these wonderful apps. You've got some of them already in the Apple store, and some of them also available through Google portals. How easy was that translation of your technologies into these solutions?
It's hard. It's hard for two reasons. To develop actually much fewer software solution, you're not just progressing your scientific agenda, exactly as you, Andrew Likaka, said. Some academics only focus on progressing the academic question. You have to actually develop something which is robust, which is user-friendly, tested with users. You have to look at different versions of the phones, compatibility issues. And there is a software development and maintenance component, which is difficult to do in the academic settings. You need different kind of staff members and personnel to do it, not necessarily people who are only interested in developing the big data machine learning models. And the funding bodies, and I'll be really interested to see what you, Tariq, can say about this. They do not cater for a long-term technological innovation. As soon as the project comes to an end, that's it. Applying for ongoing funding is a major struggle. I applied for an extension of the GAPDA project, which demonstrated behavior change in Nigeria, to scale it up across Africa, the big Zika funding by NIHR. I have got the network in Africa with Professor Shahad Gunjula, who unfortunately couldn't join because of internet issues in Lagos. She runs a network with 28 countries, all interested in scaling up this innovation around infection control and antibiotic resistance. And we didn't get the funding. And we get the comment saying it is not innovative enough, right? So the funders are not interested in actually funding something long-term, which has already proven to be successful, to scale it up. And in this case, collect more data, demonstrate more behavior change, localization to different countries, etc. they are often interested in funding something completely different. So there is a missing kind of piece of the puzzle which doesn't make it easy for people to actually translate it without setting up a completely independent startup with its own business model of subscription or some payment system, which kind of creates the link with the academia, which is essential.
Yeah.
But very, very difficult.
But you know what, Tariq Khokhar, I'm not going to put you on the spot and ask you to respond to that. Instead, I'm going to go swiftly to the audience questions because they are really, really exciting. So I've got the first one from Gina Charnley. And Gina asks, if you're using data from social media, how do you know that you're using the correct information? And she gives an example of a paper on Zika that showed that Facebook posts that were more actively shared the incorrect data. How do you address this? And this question's to you, Patty.
That's a very good question. So there's no such thing as a correct and incorrect information on social media. I think this is a wrong way of looking at it. We may distinguish between evidence-based information and fake news in a political level, in a public health level, and I think we need to do more about distinguishing the quality of the information and in often purposefully misleading the audience. However, using the information for early warning, the question is, how do we filter the noise which may distort the signal we are actually looking for? So some information could be kind of correct. It could be sharing something genuinely what the people are willing to share, which is truthful information, but it could be completely misleading if the information is built into a predictive model for early warning. So one of the biggest challenge in the social media scientific discourse is actually filtering the information out to develop something which will robustly be able to predict the right outcome we're looking for.
Great. So that leads us nicely onto a question from Nicola Ondrakova. And Nicola Ondrakova also attacks this same problem of usable and correct data. And I'm going to ask you, Dr. Philip Abdelmalik, to take this one. And she says, instead of using social media data, why can't we use data when people have actually said that they have particular symptoms? So in the UK, we have a phone number, NHS 111, which you can phone and talk about your symptoms. Why can we not use that data to show, oh my God, lots of people are coming up with a cough. There may be something coming up which could be infectious. And she hasn't said that, I've just paraphrased. Hope you don't mind, Nicola.
Yeah, thanks. Certainly, you can use that. You can use that data, and there might be a number of different responses to this. But from the perspective of public health intelligence and what we are trying to do, just like in clinical health or clinical medicine and public health too, the earlier we can detect an issue or a potential issue, and basically mount an effective response, the better the outcome. So if we can identify symptoms, for example, that people might be talking about in social media, and this is what we would typically see, is that people will talk about things in social media before they might call something in or go see their doctor. So that might give us some lead time in terms of starting to identify, not just from those who might later go and be part of a surveillance mechanism, but also those who don't. There are inherent challenges, of course, to this. There is a lot of noise. There is the idea of, are people reporting correctly or not? So there are issues around this. But the idea, I think, is not that what we are doing when we're monitoring social media, that is a replacement. It's not. It is a complementary data source that allows us to try and identify things earlier, make assessments, and then decide how we want to proceed. Hopefully that addresses it.
Yeah, no, thank you so much. That answers it really well. I've got another question for John Middleton. So first of all, John Middleton says, thanks for a great lecture, Patty. He thoroughly enjoyed your lecture, which is, as we all did. But John Middleton has a substantive question about the minimum training infrastructure required, if you're going to have this kind of curriculum. And apparently he refers to the Association of Schools of Public Health in the European region and wants to know what's the minimum training infrastructure, the the kind of curriculum that you would see, and also the ethical framework. And before I come to you, Patty, I'm going to pose this question to Tariq Khokhar. Thinking about this as a discipline, what do you think we need?
That's a very interesting question. I think I'd probably actually go back to Patty's question. Part of the answer is something that I think the software community has struggled with for a while, which is a maintenance culture. I think there's a whole lot of novelty which funders are biased towards supporting. And as a result, we end up with more kind of heat and light, if you like, to use that slightly annoying phrase, rather than thinking about more thoughtful, sort of full cycle research, which includes like building, validation, proof of societal benefit, all this kind of stuff. So yeah, if we were to shift the culture in that direction of sort of long-term maintenance, that feels like a shift that the sort of sector would benefit from, and that does require, I think, all the things that we discussed earlier. I think it does require collaboration. It does require different ways of communication. It does require a bit more humility.
Thank you very much, Tariq Khokhar. Patty, the question was meant for you. What are the fundamentals to have this as an enduring discipline?
Thank you very much, John. I'm glad to have you here joining us today. So we also have had a discussion before. So John was the president of ASTA until this year. New interdisciplinary training at the kind of master and above levels. We will be meeting the real world challenge. And what is the real world challenge? So WHO and ECDC has started looking into building kind of skills frameworks and capabilities framework for experts with digital public health background, including all the novel sort of data science, computer science techniques like serious games, app development, game-based analytics, so understanding and personalizing the app's user experience using the app collected data, and of course the predictive modeling and the social media computing, but also looking at what is the application of this into the framework of is still kind of stuck in the more old-fashioned world where the data are not interoperable, when it is difficult to agree on and share different formats. So I think addressing kind of the ethical challenges, the trust, data sharing challenges, and bringing together the expertise from both sides, so better understanding of the computing on the public health side and better understanding of the needs for public health interventions on the computing side, I think would generate the right data set for the future experts in digital public health.
Thank you very much, Patty. We lost you a little bit, but we got the gist of the response, which was excellent. And I'm going to move on to another question now posed by Luis Sabago Nunes. And Luis, again, congratulates you warmly on your lecture, and he really loves this whole event. I hope it's a he. And Luis asks a very critical question here. If we're thinking about translation, how do we make sure that when we translate, we have the right digital health literacy so that the products are going to be taken up? And actually, I'm going to ask you, Dr. Likaka, and you, Professor Albuquerque, to address this. I'll start with you, Dr. Likaka. How do we make sure we have the right digital health literacy in the general population?
Yeah, thank you. Thank you, Prof. This is a very, very important and very valid question. The world is moving digital. That has to be accepted. However, I think we are in a transition. I would say that our generation is in transition. Most of the health workers, the bulk of the health workers, professors and the like, they were born, they were used to paper-based systems. So I think what is key now is to invest more in the basics from schools, primary. I think we need to start from those areas. People should start changing their mindset. That's, I think, the basics. So it's a call to major donors. In Malawi, when I was starting in 2018, when we were trying to set up a digital health direction, one of the issues was, pilots, a disease called pilotitis in digital health. So we had almost 54 digital applications in healthcare alone. And these digital applications were focusing on primary health care. So you will find maybe one community health worker with 4 or 5 tablets. Each tablet has got a specific application. So instead of doing normal work, seeing patients, the community health worker is busy managing 5 tablets plus. And in most cases, some of these people don't know even a computer, basic use. And when we are moving with digital, I think one area I want to emphasize is that digital health should focus on a patient.
Yeah, I agree.
We need to change the direction. Digital health must always focus on patient care, patient-centered.
Yeah.
The second thing is that digital...
we seem to have lost Dr. Likaka. Professor Albuquerque, I wondered if you wanted to just quickly jump in, a couple of sentences on how do we bridge the gap? Digital health literacy versus translation of these technologies.
Yeah, this is a huge problem. That is our area that we need to improve the research and the things. And we love the way that the Patty research group do the things, that is with serious game, to translate the things in a more, how can I say, intuitive way. I think this is the main thing that we have to do, because when we are looking for digital, we are translating a continual world in a digital world with a number. We are putting numbers in the phenomena. So, of course, when we are putting number in a phenomena, we are putting errors. So, this is why we try to maintain the gap in the real information and the digital information. And for the population and for the people and everywhere, this gap is not so easy to capture. Yeah. And the games, and I think this is the best way to encourage to the people to try to break this gap. I think it's the best, a very good way. I have something to show if you. If I can, is remind that Albert Einstein in 1910 described the entire universe without digital process.
Absolutely.
What he did, he described the universe in a geometric way.
Yeah.
It's simple. This is why I am so, how can I say, proud of the work. This is why Patty wins awards after awards every year. Because she is doing this. She's broken the algebra in something easy.
Yeah, you're absolutely right. You've hit the nail on the head. If we can make it simple, it might help. I just want to now move on and ask you all to give me your final thoughts, and I'll just go around and ask the panelists this very simple question. How can we learn the lessons from this pandemic to prepare for the next pandemic, which in Europe may not take another 100 years, may come sooner than we think? I'm going to ask, of course, start with you, Dr. Philip Abdelmalik. What have we learned from this global devastating pandemic that we can put in practice to prepare for the next inevitable pandemic?
So do we have 2 hours?
You have no more than 60 seconds, please.
So I think I'm just going to maybe revert back to what I tried to say earlier and try to put this into one sentence with a lot of big words, perhaps. But I think from my perspective, we need to collaborate on building a global, semantically linked, ethically governed, maintained, trying to pick up from all the different things I've heard, an evolving information ecosystem that allows us to respond and not just react.
Thank you very much, Dr. Abdelmalik. Tariq Khokhar, I'm coming to you. How can we prepare?
Yeah, well, I think prepare is, of course, the watchword here, but maybe focusing on the how. And I think, again, going back to my earlier comment, I think we have to put trust into practice and make sure that the research data and tech that we're developing to respond to the next pandemic are truly trustworthy, and that they're trusted by society as a whole, and not just the relatively elite few who can understand what's going on under the tent. So trustworthy and trusted by society as a whole.
Thank you very much, Tariq Khokhar. Dr. Likaka, how can we prepare?
I would say, I think there is a lot of sharing taking place, but it's also in the silos. So a lot of efforts happening, but they are not documented. Best practices. So I think setting up a platform where learning, sharing, and documentation is reinforced will be a key milestone to prepare for any emergency coming. Thank you.
Thank you. I mean, WHO and the Wellcome Trust, you've heard it. And Professor Albuquerque, 2 sentences. How can we prepare?
I think we have to change absolutely how we think about pandemic. This is objects that if we use some digital system, we'll conclude that all of them are circles. No one will conclude anything else. But they are not. They are just projections. This is what COVID is doing with us.
Okay.
So we have to change our mind and the way that we view the thing.
Wonderful. So Patty, I'm going to come to you. We've heard about being connected. We've heard about making sure we have data we can trust. We've also heard about making sure the data is good quality. And we've heard about bringing that all together on a platform. What can you add to that? How can we prepare?
I would go back to, I wouldn't be able to repeat all the fantastic questions, and I think Philip has put it so eloquently about the platforms and the data. So I'm not going to repeat that. The only thing I think we have not discussed yet in the preparedness for the next pandemics is capacity building. Is making sure we develop the capacity on the ground in a time when there is no pandemic, in a peaceful time, in quotes, when it is not everyone's business, it's not on a political agenda, it's not in the news every day. The funders move on, funding something different, researchers move on, doing what they did before, when it's boring topic. At those times, I think we have to make sure the capacity building and the training remain funded and solid globally in order to hit the next pandemic with much better resource, much more interoperable and ecosystems, semantically linked, and much better trained workforce.
So you talk about the trained workforce and capacity building. What about members of the public? Because there might be people listening to this who are not medically trained, they're not scientists. What can members of the public do to prepare themselves for the next pandemic?
Excellent question. So I will go back to Louise, who had this question in the FAQ a few minutes ago. Thank you for the question, Louise. Great to have you here. I think public can definitely empower themselves in better understanding for internet literacy. Some of the issues we have been seeing in the world of the social media and our decision-making as a society in the last 5 years, the right-wing, racism, white supremacy, obviously the anti-vaccinations movements, COVID deniers, this has been enabled, obviously, by certain powerful people and funders, but also it has been accelerated by people not being able to distinguish between what is evidence-based and truthful and what isn't. So becoming less gullible and more internet savvy, I think, would be what the public can do to help the scientific community and the funders to prepare for the next pandemic. Well, we all should be having a better quality of life.
So you want them to be less gullible. That's very difficult if you're someone who's easily if you pander to your beliefs. I don't know how I can become less gullible. Because when I read something and it really resonates with me, I'm probably more likely to accept it as the gospel truth. How can they become less gullible, Patty?
That's true. That's why we have these kind of echo chambers on the social media where people trust the information which is in their echo chamber much more easily because it resonates with their value system or with the opinions of their friends, and they would not see the other chambers. So I think being open to differences in opinions, and not just differences in terms of having a fair debate on the BBC, but differences where we would genuinely try to seek the truth and the evidence in the healthcare system is where I think we can all move forward.
Brilliant. Thank you so much. I'm going to thank my panel. Tariq Khokhar, thank you so much for lots of insightful views, and hopefully you'll take some funding ideas back to the Wellcome Trust. Thank you very much, Dr. Andrew Likaka, especially telling us about how technology sometimes can be a burden for people that have not had a lot of training with computers and things. Thank you, Professor Albuquerque, for actually making the point that the data has to be excellent and well presented for it to make an impact. And Dr. Philip Abdelmalik, you reminded us that prediction has been here for over 200 years, close to 200 years or 150 years or so. We didn't invent it. And we just have to make it better. Thank you so much. You've been fantastic panelists. I'm going to hand you back now all to Professor Patty Kostkova. And thank you to Patty for not just your lecture, but also the excellent participation in the panel.
Thank you so much, Ijeoma. You are a fantastic chair. Obviously, I've seen you before as a fantastic chair, and I was so delighted when you agreed to participate as a chair of the panel today. So thank you so much for leading us through this debate and really getting to the nitty-gritty details of how we can prepare for the next pandemic sector. Thank you, everyone, for staying with us until almost the closing point of time. So it's your opportunity again. We have a little poll, a few questions for you to answer, how much you enjoyed and what you learned at today's event. So the poll should be just up, and we have, again, 30 seconds to answer a few questions about today's event. Please make your votes now. There are 3 questions, so make sure you slow down. So we're asking you how people enjoy the event and if they got inspired. So let's see what people say about the inspiration and where it comes from. And also we would like to know how you have learned about the event, because we would love to stay in touch with you in the future. So far the event was excellent. Excellent. No one has voted that it was below expectations. Wow. Putting these questions on a live vote is always a bit dodgy. What if a lot of you said it was below expectations and it would be a live result I would have to show right now? So I'm delighted. A lot of you, 73% thought it was an excellent event. No one thought it was below expectations. I'm really proud of that. The majority of you found information and gained knowledge into the domain, which is excellent. This is where we can all move together in improving our understanding of digital health at a personal and a professional level. People are excited about the future of digital health, 50%, that's great. And we have people who have learned from us from a word of mouth, from our newsletter, and also from other sources. That's excellent. So thank you for letting us know what you think. Thank you for joining us. And we also will be in touch with our feedback form a few days later. And we also have launched our dPHE report. So if you want to learn in a bit more detail about the work I have presented here today and the work my team has achieved, do read our report. Loads of pictures and loads of achievements across the projects I have demonstrated with higher detail. And we would love to hear from you back. So we're coming to an end of the inaugural lecture and the second dPHE anniversary. It's my pleasure to hand over to Professor Peter Simmons, the Director and Head of Department, as he has learned the youngest department at UCL, Institute of Risk and Disaster Reduction, which is our home. Over to you, Peter.
Well, thank you very much, Patty, for a magnificent inaugural lecture, and I guess it's how you'd expect things from a professor of digital health with an online digital presentation, to have polls, to have an online panel, and a really very entertaining. It was very important, I think, in setting up the centre in the first place. But of course, it is really Patty's leadership of the centre and developing it really just from her